I'm very happy that we have Professor Fourou with us here today to talk about the domiciliary use of NIV in pediatrics and what to do in 2022. Professor Brigitte Fourou is professor in pediatrics and head of the Pediatric Non-Invasive Ventilation and Sleep Unit and the Respiratory Physiology Laboratory at the Necker University Hospital in Paris, France. A very warm welcome, Professor Fourou, and the floor is yours.
Hello, it's a great pleasure and a great honor for me to share with you this first webinar from 2022. And I think it's a great honor for pediatrics to start this year on this topic. So a major breakthrough on pediatric NIV was the publication at the end of last year on our URS statement on pediatric long-term non-invasive ventilation. This statement, on which we worked for 2 years with 16 members, experts from Europe and Canada, made an extensive analysis of all the literature published on long-term NIV and CPAP in children. You can see here the list of the 17 URS task force members who came from a lot of European countries, but also Canada, who was represented by Joanna McLean, and also Refika Ersu, who represented both Turkey and Canada. So I thought it was probably interesting to go through the different topics of this task force and share with you some of the interesting points of this task force, with a special focus on recent publication that have been performed after the end of the bibliography search of the task force. Indeed, in this statement, we made an extensive literature analysis until April 2019. So in this presentation today, I will share with you some more recent publications dealing with pediatric long-term NIV that have been published in 2020 and 2021. So in our task force, we divided the task force in 12 different points. And the first was disorders that may benefit from CPAP and NIV. So just to give you an overview, in France, we have built up a pediatric network on long-term NIV. And this network comprises 28 pediatric university centers who all deal with long-term NIV in children. And all those centers are distributed all over France. So we made an analysis of the number of patients who were treated with long-term NIV in France on the 1st of June 2019. At that date, there were 1,448 children on long-term CPAP or NIV in France. And you can see here the very large list of the different underlying diseases of the children. So the most important group were children with upper airway disorders, and you can see that most of those children had rare or genetic diseases. The second group, nearly 400 children, were children with various neuromuscular disorders, followed by children who had abnormalities of the central nervous system, then children with cardiorespiratory disorders, congenital bone disease, and finally some other rare disorders. And here you see the number of patients in the different subgroups. The largest group, 670 children, who were treated with long-term NIV because of upper airway obstruction. Then 400 children with neuromuscular disease, central nervous system, cardiorespiratory, congenital bone disease, and other. What was interesting also here were some of the characteristics of the patients. At the time of the study, the mean age of the children was between 8 and 11 years. And they had been long-term NIV since 1.5 up to more than 3 years. You can see that according to the underlying disease, they had predominantly CPAP, like in the children with upper airway disease, or NIV as the group of children with neuromuscular disease and children with central nervous system disorder or cardiorespiratory disorders. What was particularly interesting in this study was the percentage of children who were initiated on long-term CPAP or NIV, either electively or just after an acute respiratory exacerbation. And I think thanks to the systematic screening of these patients at high risk of severe obstructive sleep apnea or alveolar hyperventilation, you see that only 8% of the whole cohort were started on long-term CPAP or NIV during or immediately after an acute illness. That means that in France, the most of those children are appropriately screened before an acute respiratory event. Here you can see the objective compliance of the patients with their CPAP or NIV with data taken from the inbuilt software of the devices. And you see that the mean compliance of those children were very good and not different between one group and another. As you can easily understand, most of the children used a nasal interface, and also concerning the ventilatory mode, there were only 18% to up to 15, 12 and 16% who used a mode that integrated the use of a target volume. Also, we had information on the type of NIV device, and you can see that here the patients with neuromuscular disease are those who have most often a life support ventilator. So in our task force, we also underlined some groups of patients in whom long-term NIV was not performed on a routine basis. So I just present you here some recent publication on the long-term use of CPAP in children with special diseases. And one group is laryngomalacia. Mostly around the world, well, when children have severe laryngomalacia, they often have a tracheostomy. Here in our hospital, we have a large experience of long-term CPAP. So we analyzed a large group of children over a period of 10 years who were managed for severe laryngomalacia. And we observed that long-term NIV, long-term CPAP, was initiated in 3 different medical conditions. First, those who failed surgery. Then those who had laryngomalacia sufficiently severe to be admitted to the pediatric ICU for acute respiratory failure. And then there was a third group with children who had associated comorbidities who did not allow an endoscopy and a surgical treatment. So you see here that in the group of 188 infants with severe laryngomalacia, long-term CPAP was proposed after failure of surgery in 24 patients. in case of acute severe respiratory failure in 9 infants, and here in 5 infants because of underlying abnormalities that contraindicated a surgery. You see that when a sleep study was performed, they had an extremely high apnea-hypopnea event, reaching almost 49 events per hour. You see that the duration of long-term CPAP, the mean duration was 3 months, and that the mean age at weaning from long-term CPAP was 11 months. Of course, after weaning, the correction of sleep disorders breathing was checked by normal gas exchange, no clinical symptoms, and a normal polygraphy with an apnea-hypopnea event within the normal limits. The risk factors for long-term CPAP were the need for a second surgical revision or the need for nutritional support. We saw from our national survey that long-term CPAP or NIV may be also proposed in congenital bone disease. In our hospital, we have the National Reference Center for Congenital Bone Disease. And we did a systematic analysis of all the sleep studies that were performed in 31 consecutive children with skeletal dysplasia. And here you can see the list of congenital bone disorders. And we observed that in 16 of the 31 patients, there was obstructive sleep apnea, mostly mild, but sometimes moderate and severe. And importantly, despite upper airway surgery, 1 patient needed treatment with CPAP and 3 with NIV because of persistent nocturnal hyperventilation. So this study underlines the need for systematic screening of sleep disorders breathing in all types of skeletal dysplasia in children. Another rare disorder needs to be known by pediatrician. It is Chiari malformation type 2. In this case series, we looked at the sleep studies that were performed in 8 children with Chiari malformation type 2. And you can see here that there were 6 of the 8 children who had obstructive sleep apnea who was severe in 3 children, with 2 children needing long-term CPAP and 1 patient long-term NIV because of nocturnal hypoventilation. The second topic of our task force concerned the initiation criteria, the location of initiation, and also the recommended optimal settings. So here you see a figure representing here the summary of the international literature. Concerning NIV, it is recommended to start with an expiratory pressure of 4, an inspiratory pressure of 8, and then progressively increase these pressure levels according to the tolerance of the child, either during the day or more progressively during 1 or several nights. Mean therapeutic pressures are generally in children an expiratory pressure between 4 and 6 and an inspiratory pressure between 10 and 14 with a backup rate for children with neuromuscular disease. Of course, it is mandatory to control the efficacy of your settings, ideally by a polysomnography or polygraphy, or at least overnight gas exchange recording with CPAP or NIV when the child is acclimatized to treatment and is able to sleep the whole night with his treatment. So this is an interesting study published by the group of Essen managed by Florian Staling, who is member of the US task force. And very interestingly, they looked at the ventilatory settings in a large group of different ages in children with neuromuscular disorders. And they looked at the settings that those children had at home for their long-term NIV. You can see that across all age group, the expiratory pressure were not different. They were between 4 and 6 centimeters of water. The same for the inspiratory pressures, although there is a greater variability in the older age group, the mean inspiratory pressure was not different across the 4 different age groups. However, you can see that the backup rate decreased when the patients became older, and this is explained by the physiological decrease of the respiratory rate. So there is very few literature on the comparison of different ventilatory mode for long-term NIV in children. So this study was published last year and concerned the comparison of 2 different ventilatory modes in 20 children on long-term NIV for neuromuscular disease. The mean age of the children was 12 years, 16% of the children had Duchenne muscular dystrophy, and the design of the study was first 3 months in the ST mode, followed by 3 months with the VAPS mode. And you can see that here the compliance was significantly better with the VAPS mode as compared to the spontaneous time mode. There were more days with a use more than 4 hours per night, and the average daily usage and mean daily usage were also better with the VPAPS mode as compared to the spontaneous time mode. However, there was no difference in all polysomnographic variables, no difference with regard to sleep quality, sleep architecture, gas exchange, inbuilt software, and also on the subjective sleep and comfort evaluated by the patients themselves. However, concerning the design, it was not a randomized period. Also, the fact that they started always the spontaneous followed by the VAPS is a limitation of the design of the study. Let's now switch to the follow-up of the patients. In the task force, the conclusion of our literature analysis was that after the initiation of long-term CPAP or NIV in the hospital, the minimum follow-up should include a visit at 1 month, at 3 months, 6 months, and then at least every 6 months. Of course, the follow-up should be closer in case of young children, children with severe underlying disorders, or difficulties or problems concerning the family. According to the different healthcare system in the country, this visit can be completed by visit by the home care provider, as we are able to have in France, who can monitor at home the overnight gas exchange and also communicate to the hospital team data from the inbuilt software. One very important help for long-term NIV is the data given by the inbuilt software of the different ventilators and devices. Especially if you look, for example, at a night with the addition of a pulse oximeter connector connected to the ventilator, that allows you to have access to the different respiratory parameters of the patient in combination with the pulse oximetry. And when then analyzing by a breath-by-breath analysis of the patient breathing during the night with his CPAP or NIV, you can have a very good estimation of the respiratory events that could be performed by a polygraphy. In this paper published by our team, you can clearly see that you have a very good similarity of here an obstructive apnea on the polygraphy and the inbuilt software data, an obstructive hypopnea, and a central apnea. So when you try to analyze the inbuilt software like a polygraphy by performing a manual analysis breath by breath with the use of pulse oximetry, you can have a good agreement of the control of sleep disorders breathing by the inbuilt software of the ventilator. Also, you all know that the inbuilt software of the ventilator gives you very good information on the flow, on the leaks, on the expired tidal volume, on the triggering of the patient, and also of the compliance. So in case of difficulties to have access to polysomnography or polygraphy, the use of the inbuilt software is a very, very useful and cheap way to control the correction of sleep disorder breathing of your patient by the CPAP or the NIV. Concerning now the compliance, people think that patients with neuroobesity or mental retardation may be less compliant to CPAP or NIV than children without neurodevelopmental delay. However, this study shows the opposite. This is a retrospective study where they compared compliance in 44 children with Down syndrome compared to 62 non-Down syndrome patients. What you can see here that the black bars who represent the patients with Down syndrome, they had more severe obstructive sleep apnea, but they had a very good compliance even in all the different age group compliance who was not significantly different than the patients who did not have a Down syndrome. A new area of follow-up and management of patients on long-term NIV is telemedicine and telemonitoring. We have seen during the last 2 years, because of the COVID epidemic, that a lot of centers adopted at least a partial televisit, telemedicine or telemonitoring. So there are quite a lot of observational and experience papers published in the literature last year. To make a summary, the advantages of telemedicine is that it allows a face-to-face interaction, of course by means of the internet, but it's indeed better than no follow-up or a follow-up by the telephone. It is also very easy and allows us a close follow-up. There's no need for travel for the patient and his family. It saves it saves time. It limits school and parent caregiver work absence. It limits virus exposure. Multiple caregivers may be connected at the same time, and the child is in his home environment. However, telemedicine has some limitations. For example, clinical examination, obstructive sleep apnea symptoms may be better evaluated in office, and physical examination is limited. There's also the problem of the language barrier. Of course, internet is required. The fact that the child is in his home environment may be an advantage, but also a limitation. And also there may be reimbursement problems in some countries. In our task force, we underlined also the importance of the preservation of the quality of life in children and parents. And the literature is quite scarce on this topic. And what we observed in our experience is that most often the siblings of children who are treated with long-term NIV are neglected. And we think that the whole family, not only the parents and the caregivers, but the siblings should also be involved in the long-term NIV or CPAP of a patient. So we made an analysis on the emotional status and mental health of 79 siblings of children treated with chronic NIV. And you see here the list of disorders, which for most are really severe disorders. And we administer to the parents a specific questionnaire on mental health. And you can see that here, when you look in the young age group, the age group 1.5 to 5 years, you can see that here 19 and 13 children were borderline, and 6%, just one child, had really significant internalization problems. So that represent both 13 and 31% of the young age group. For the adolescents, you can see also here that here 13% of the older children were borderline and 10 were scored with clinical symptoms, both for internalization and externalization. So these results show that there is really an impact of the illness and treatment of the affected children in some siblings. And also when we made a more specific questionnaire on the feelings of the siblings, we observed that the majority of siblings felt deeply responsible for their affected sibling and were very strongly involved in her illness and non-invasive ventilation treatment. For example, we observed that most brothers and sisters checked that the affected sibling was correctly using his nocturnal CPAP or NIV. A very important point was also therapeutic education for CPAP and NIV. Most of centers dealing with long-term NIV have their own tools for therapeutic education. Here in Paris, we have a teddy bear that mimics a child having either CPAP or NIV, which is really very helpful to de-stress children in whom we are starting CPAP or NIV. We have also here a booklet for young children explaining the rationale of CPAP and NIV. And as I said, we are also giving this booklet to the brothers and the sisters. Then we have just an example here of the checklist of all the competencies that the caregivers must have before the discharge of the child on long-term CPAP NIV at home. Also, we made here this book, which we made with the caregivers, all the different healthcare professionals involved in long-term NIV in the hospital and at home, and also with caregivers and parents of children treated with long-term NIV. So this booklet is available, so if you want to have an inspiration or to translate it in your language, it is not a problem. So the booklet first explains exactly how the respiratory system works. Then why the child needs long-term non-invasive ventilatory support. Who are the persons who will be involved in the initiation and follow-up of the NIV. Then we explain how the device, the circuit and the interface works, how the ventilator works, how we choose the interface the most properly adapted to the age and the comfort of the child, how the mother is also trying at the same time, and the nurse and the doctor finally choose the ventilator. Then we show how the ventilator works, how he first tries awake or during a daytime nap, and then during the night, and then how the ventilator becomes part of his daily life. So this study was also performed last year. It was very interesting because it evaluated the benefit of an information booklet for the parents. So here were the different topics that were explained in the booklet, and then when they compared here the different scores of clarity between parents who did not receive the booklet and parents who received the booklet, all the different scores on the information, the clarity, and so were significantly better in the parents who received the booklet. So as a conclusion, I think that it's not surprising for you that long-term CPAP NIV is expanding worldwide in children. This is accompanied by increasing complexities of children. There are also new indications, and CPAP NIV is more and more proposed in children with neurodisability or as part of palliative care. However, there is still a lack of validated criteria for initiation, optimal follow-up, monitoring and telemonitoring, and weaning. Also, there is a very large chapter on management of CPAP or NIV failure, who should be adapted to the individual patients and his underlying disease. Most important, therapeutic education and the preservation and improvement of quality of life for the child and the family comprising the siblings is an essential part of the care of children needing long-term CPAP NIV. And also because of the complexity and the multidisciplinary need of these patients, they need to be followed by an experienced pediatric multidisciplinary team. Thank you for your attention.
Thank you very much, Professor Verhoef, for this very informative and interesting presentation guided by the results from the ERS task force. We have received a number of questions during your presentation here in the chat. I do invite the audience to keep those questions coming, even now here during the Q&A section. When I look at the chat here, there's a number of questions, and the one I'd like to start with is what would be your tips for increasing adherence in children who need respiratory support?
I think first it's extremely important that the parents and the caregivers and the child understand why he needs CPAP or NIV. So the first thing I do is to explain the breathing and what is abnormal in his breathing. And with that regard, we very easily show the results of pornography with the apnea. We always show the results of the overnight gas exchange. So the parents really see the desaturation, the hypoxia, the hypercapnia. At the same time, we also put no pressure on the child and the family. We say, yeah, you are afraid because it's a device. It looks very stressful, but a healthy child will not need it. But your child, because of his abnormal breathing for him is an effort, and he will be relieved, and he will be supported and return to normal breathing and a restoring sleep with the device. So we said, you have to try. It is the doctor's role to find the most comfortable interface and also the appropriate and optimal settings. So it is a two-component contract. First, the parents and the child have to understand and make the effort to try, and then it is the hospital team to make the CPAP or NIV the most comfortable possible. Then we make very short-term objective. The first is you try to increase progressively and every night to use the ventilator a bit more. So the first objective is a short-term objective of, for example, sleeping at least 4 hours and then sleeping the whole night. So it's a very step-by-step, close follow-up, which has also the advantage to immediately detect when there is a problem, so that the parents and the patient feel really supported and not afraid to ask questions and not be discouraged because there is a problem. So it's a step-by-step contract, and that explains, I think, also why we have in France such excellent compliance rates. Because in all our previous study, where we assessed objective compliance by mean of the inbuilt software data, the mean compliance is more than 8 hours per night. So that means that nearly all our patients sleep the whole night with their ventilator.
Okay, great. Thank you for the answer. Another question here on the chat is that you have spoken about experienced multidisciplinary teams for the treatment of the pediatric patients. What, in your opinion, constitutes, what are the team members for such a good and experienced multidisciplinary team?
First, I think that there should be a pediatric pulmonologist or a sleep specialist or an intensive care doctor who has an experience in pediatric sleep disorders breathing, who is able to make the diagnosis. This team should also have an experience and knowledge in ventilators, devices, and interfaces. Then, according to the underlying disease of the child, you may need different multidisciplinary teams. Of course, if you take a child with neuromuscular disease, you need a pediatric neurologist, physiotherapist, cardiologist, re-education, physiotherapy rehabilitation, and a pediatric psychologist. If you have a child who has, for example, Crouzon disease or Appert disease, which is deals with facial craniostenosis, then you need pediatric neurosurgeon, ENT, maxillofacial, orthodontist, and of course also pediatric psychologist and social worker. So just an example, according to the underlying disease, for example, a child with Prader-Willi, you need a pediatric endocrinologist. So according to the disease, you need a specialist of the different multi-organ involvement associated with the disease. And of course, you need also a team that will help you for the follow-up at home. According to the countries, this home team may vary. In France, for example, we have home care providers that are specifically trained for pediatrics with technicians, physiotherapists, nurses who are trained in pediatric NIV, who work with us on a daily basis, and who are those who do the home visit. In the Netherlands, it's different because this team is directly related to the hospital pediatric NIV center. What I explain is that if you have a child who needs long-term NIV, you need in your center the different pediatric subspecialties that are required for the underlying disease of your patient.
Thank you. There's three more or less, let's call it technical questions or related to settings. Is there an ideal frequency compared to the physiological frequency to set the backup rate?
The backup rate is mainly mandatory for children with neuromuscular disease. Why? Because their respiratory muscles are weak, and the aim of nocturnal NIV is to assist the respiratory muscles when they still have some strength, or to completely replace the respiratory muscles when they are completely paralyzed or too weak. So the aim of NIV is to replace the normal breathing. So that means that you must have a physiological tidal volume entering the lungs of the patient at a physiological breathing rate. If you have, for example, a baby 3 months old, a healthy baby during sleep will breathe with a respiratory rate of 30 per minute. If you have a child of 2 years old, he's breathing with a respiratory rate of 20 breaths per minute. If you have a 14-year-old boy, it will breathe with a breathing rate between 12 and 14. So if you have a patient with neuromuscular disease, what is generally set in those patients is a backup rate which is either 2 or breaths below the physiological breathing rate for the age of the patient, or the same the backup rate which is similar to the physiological breathing rate of a child for his age. I don't know if I'm sufficiently clear.
Yeah, I think that was very clear.
There can be just one more comment.
Sure.
There is, for example, an exception in children who have severe restrictive lung disease. For example, infants with achondroplasia. They have a very small chest, so they have a rapid shallow breathing. And their breathing rate at the age of 1 year may be, for example, 45 or 50 breaths per minute. Same for an infant with Jeune syndrome. If you have a baby with extremely severe bronchopulmonary dysplasia, his respiratory rate will also be very higher. So it depends also on the underlying disease of the patient. However, the aim of NIV is just to restore a normal tidal volume or minute ventilation. Just to remember, the normal tidal volume of a child is around 10 milliliter per kilogram.
Thank you. Also around the setting, different setting this time, do you have experience with EPAP pressures lower than 4 millibar, as some devices allow for a setting down to 2 centimeters of water of expiratory positive airway pressure?
Normally, yeah, it's a question. Normally, if you have a single circuit with a titrated leak, the expiratory pressure is just there to avoid the rebreathing of exhaled air. So your expiratory pressure must be sufficient to avoid the rebreathing of CO2. So normally, this expiratory pressure is 4 centimeters of water. If you have a child, for example, who has a neuromuscular disease or a restrictive lung disease, without any evidence of upper or lower airway obstruction, you don't need high expiratory pressure. Your expiratory pressure will just be there to avoid the rebreathing. So if with a level, an expiratory pressure of 2 centimeters of water, the child has no associated upper airway obstruction and there is no rebreathing, you can use an expiratory pressure of 2 centimeters of water. However, if you have a child, for example, who has Down syndrome or achondroplasia and who has an associated upper airway obstruction, then you have to titrate your expiratory pressure at higher levels in order to correct this obstructive component of breathing pattern.
Thank you. The last one here, more technical. Although the webinar is on CPAP and NIV, but are there any situations where you use high flow nasal therapy for your patients?
I really recommend the audience to read the URES task force. There is a whole chapter on CPAP or NIV failure. And high flow nasal cannula is discussed in this chapter on CPAP failure. Indeed, we also have published a paper on 8 children with severe obstructive sleep apnea who were not able to acclimatize to CPAP, mostly because of mental retardation. And in those children, we proposed high flow nasal cannula as an alternative to CPAP because of CPAP failure. In 5 of the children, high flow nasal cannula was extremely well accepted by the patient with a good compliance, and on a respiratory polygraphy was able to correct the sleep disorders breathing. However, in 3 adolescents with Down syndrome, with severe lack of cooperation and mental retardation, even the high flow nasal cannula was not accepted. So it can be an alternative to CPAP if there is failure of optimized CPAP, but of course you have to check that the high flow nasal cannula is able to correct sufficiently the sleep disorder breathing of the child. Of course, there are a lot of limitations and disadvantages of high flow, and the main disadvantage is that you don't have a stable pressure and you are not able to control the airway pressure of the high flow nasal cannula.
Yeah, thank you. Another good reason to consult the ERS task force publication. You also mentioned telemonitoring, and there's a question from the audience. How do you use telemonitoring now today in your unit?
We use it all the time because in France we still have a very strong epidemic. But the problem is that we have reimbursement problems. It's really time consuming, and at the moment there is no, je dirais, official recognition and reimbursement of this type of consultation. Also, we have problems with families who don't have internet or who don't speak French sufficiently well to be able to have a telemonitoring. But at least it is a helpful additional tool to optimize follow-up in difficult patients.
Okay, thank you. The last question which we have here on the chat is, which patients do you find the most challenging?
There are different types of challenges. First, on the medical point of view, is that the patients who are too severe. If you have patients really with too severe upper airway obstruction and even extremely high levels of CPAP don't work, even the switch to NIV, the only solution that is left is tracheostomy. The same for patients with progressive severe neuromuscular disease. When exclusively nocturnal NIV is not sufficient, we extend the NIV use during the day. In older children with mouthpiece ventilation. But if this is not sufficient, then you will need to discuss a tracheostomy in those children by really transparent information to the parents and of course the patient. Then you have another type of challenging problems, which are children who are not compliant. And there are, to my opinion, two difficult groups. First, older children, adolescents with Down syndrome, who have not been treated for their obstructive sleep apnea since infancy. Those children are really poorly cooperative, have severe mental retardation, and they don't accept anything, not only CPAP or NIV, but all other type of medical treatments. So this is really a very difficult group. The other group, which is really disappointing and desperately non-compliant, are adolescents with severe morbid obesity. Even if you invest the most you can, they are not compliant with the CPAP, they are not compliant with their diet, they are not compliant with their physical activity, they are not compliant with their psychological support. So really obese adolescents are, in my experience, a very, very difficult group.
Okay, thank you very much. There's no more questions in the chat, so I would like to thank you as audience to participate to this webinar.